Okay, so yep, John, you're going to be our sixth presenter for today. And the title of John's project is Development of a 3D printed Pediatric Dosimetry Phantom for the validation of PCXMC for cone beam CT. So John, I've started the recording. Take it away when you're ready.
All right. Yep. So like Jake said, my project title is Development of a 3D printed Pediatric Dosimetry Phantom for the validation of PCXMC for cone beam CT. I'd like to thank my supervisors, Ricky Nezic from MedTech and Physics and Dr. Pejman Roche from Farzad. So what is cone beam CT? So cone beam CT is a rotational radiography technique that combines the large beam area of a planar X-ray with a reconstruction of a fan beam CT. So what this allows for is fast acquisition of 3D images without needing to move the patient throughout the beam, as you can see in the figure below, where in the fan beam CT, the patient needs to be moved forwards and backwards. And the image to the left is the Siemens Zigo, which is one of the new C-arm cone beam CT equipment that we have at Perth Children's Hospital. So what are some applications of cone beam CT? Well, there's applications in both medicine and dentistry. In medicine, the applications would be interventional radiology, dual X-ray absorptiometry or DXA, and image-guided radiotherapy. And then in dentistry, for oral and maxillofacial 3D imaging, and then also orthopantomograms or OPGs for short, which are essentially a panoramic image of the oral cavity, as seen on the figures on the right. So what is PCXMC? So PCXMC stands for PC Program for X-ray Monte Carlo. And it's a program used by the medical physics team at both Sir Charles Gairdner Hospital and Perth Children's Hospital. And what it essentially is that it provides a simulation of planar X-ray procedures to gain dosimetric insight onto the individual organ doses, as seen in the screenshot on the right. So the Phantom is built from the Christie and Eckermann 1987 Phantom, which is described by a series of mathematical parametric equations, which essentially build volumes of cylinders, spheres, ellipsoids, etc. So not only is the actual whole Phantom built out of these equations, but also the individual organs themselves. So these, for example, the ribs are built from spaced cylinders. So the software offers adjustability in both the Phantom dimensions. So we can see that the Phantom has age 0, 1, 5, 10, 15, and adult, which essentially scales the Phantom and changes the dimensions of the organs as well. And then the beam properties of the X-ray can also be adjusted, such as the field size, as well as the actual energy of the X-rays in keV and the number of photons, so essentially the MAS. Combined with PCXMC AutoCalc scripting, hundreds of planar projections can be taken around the Phantom, essentially simulating a cone beam CT procedure where we have a planar X-ray that's rotated around the patient. So, statement of the problem. So cone beam CT is increasingly popular in medical and dental applications, like mentioned before. And there's a couple of new cone beam CT systems at both Sir Charles Gairdner and PCH that produce dose quantities like dose area product or DAP that are only applicable to planar radiography. So you can see the image on the right is that if we have a planar X-ray, the beam area times the air kerma will be our dose area product. And the reason why a lot of these systems produce these planar quantities is because they're essentially fluoroscopy equipment that have the ability to rotate. And the problem is that there's no direct conversion between DAP and rotational quantities like CT DI vol and DLP, dose length product, which is acquired by finding the dose per ring of a helical acquisition, and then we times that by the length of the acquisition. So it's difficult for staff to understand the associated radiation doses with cone beam CT in terms of normal fan beam CT doses. And on top of this, there's a number of different spin protocols with different beam parameters. So for example, MAS and KV are altered between these different spin protocols. And so the doses are still relatively unknown. So probably wondering, why can't we measure the doses directly, for example, stick an ion chamber or a diode dosimeter into the beam? And yes, we can if the beam parameters are fixed, but under the automatic brightness control or ABC, the dosimetric equipment can't be used because the ABC will alter the beam parameters, such as the KV, the MA, copper filtration, pulse width. However, this is avoidable by simulating the procedure using the same beam parameters like KV and MA in PCXMC. So the problem is that the PCXMC AutoCalc and the entire process of simulating it has to be verified using an anthropomorphic phantom. But the benefit of using PCXMC, if it was validated, is that the computer-based simulation will improve workflows in radiology rather than having to stick an anthropomorphic phantom into a beam every single time for validation. So this brings me to the significance of this study. So without an in-depth understanding of doses involved, like mentioned before, it's difficult for staff to assess the risk-benefit ratios of cone beam CT procedures. And this makes it difficult for justification and optimization of procedures. And then it also reduces the optimization of the radiation protection of patients. In particular, pediatric patients are more at risk of radiation-induced cancers because of their faster self-proliferation rate, as well as their longer life expectancy. So orthodontics is a field which uses OPGs quite often, which, as mentioned before, is an application of cone beam CT. And because orthodontics, there's going to be lots of children having these, seeing an orthodontist, children will receive on average a 33% higher effective dose compared to adults by a study conducted by Paulers in 2014. And this was attributed to the closer proximity of radiosensitive organs, such as the esophagus, thyroid, and salivary glands within the beam, because with the same field of view as the adult OPGs, the thyroid and other radiosensitive organs were included in the beam. And then this resulted in estimates of 2 times a higher risk of cancer, more than 2 times a higher risk of cancer compared to adults. So because of this, it's really important that the radiation doses from cone beam CT to be validated, especially for pediatric cases. So a couple of studies have actually found this significant, and they've investigated the doses of PCXMC using anthropomorphic phantoms. So a study by Wood and Moore in 2015 verified PCXMC simulation of cone beam CT for prostate imaging with a rando phantom, which is a type of anthropomorphic phantom. And they found quite a decent dose correlation coefficient of R squared being 0.995. But they also found that 80% and 60% dose differences were found in the liver and stomach, where the PCXMC underestimated the doses compared to the rando phantom by that huge margin. It's understandable why, though, because the anatomy of the rando phantom is different to the anatomy of the PCXMC phantom. So because the liver and stomach are quite far away from the prostate, the main factors that cause the doses would be scatter. And so the different anatomy would cause quite different scatter properties. And then another study by Kim and Han in 2018 investigated the dose verification for cone beam CT of dental procedures with an Alderson radiotherapy phantom, which is essentially a revised version of the rando phantom. And they again found that PCXMC underestimated the doses of different field sizes, so by 16 to 18%. So there's a gap in the literature where there's no verification of PCXMC with the actual Christie and Eckermann phantom, which is the phantom that PCXMC is based on, which brings me to the aim of this project. So the primary objective of this project is to design and develop a dosimetric anthropomorphic phantom based on the Christie and Eckermann newborn phantom using 3D printing. So the proposed phantom will be printed in 25 or 2.5 centimeter slices with holes for thermoluminescent detectors, similar design to how the Rando and the Atom phantoms are made. And then when constructed, the phantom will be used to verify PCXMC's dosimetric simulations of a number of different cone beam CT procedures. And then that way we can have a better understanding of the doses involved with cone beam CT. And then if PCXMC is indeed validated, then we can, like I said before, improve those workflows and allow for easier dose verification of other cone beam CT procedures. This image on the right is a thoracic region slice that I generated in MATLAB with TLD holes included. So you can see the lungs, the heart, the spine, and the arm bones in that region. So the phantom will be printed in these kinds of slices, or all along from head to toe. So some key benefits that will arise from this study, as mentioned in the significance, was that having a PCXMC specific phantom will allow for accurate correlation between measurements and simulation. Like we saw with the Rando phantom, there was quite a lot of differences in dose because of those differences in anatomy. And also, not to mention, it's a huge decrease in cost compared to outsourcing a phantom. So for example, the CIRS Atom phantom for the newborn costs 38,000 AUD, whereas the price proposed for this project will only be about 400 AUD for all the filaments and everything. And also some other systems like RadimetricsTM, which is a new dose verification system for not only CTs, but also planar radiography that's employed at Charlie Gardner, uses the Christie phantom. So the Christie phantom that will make for PCXMC validation can be used for the validation of Radiometrics as well. So this brings me to my methodology and study design. So first of all, we'll need to do 3D filament and infill testing so that the filaments best replicate the X-ray attenuation properties of the 3 different tissues in the Christie phantom, which are lung, bone, and soft tissue. And then after that, after calibration curves are done and the filaments are selected, we'll complete the model in MATLAB. And then we'll move on to printing. And then after that, we'll need to do some TLD spacing testing. So we want to maximize the amount of TLDs in the phantom as possible. Like Tom said earlier, we want to, because TLDs are known for their uncertainty sometimes. So if we maximize the amount of TLDs, we're going to have reduce the amount of statistical uncertainty. But we also don't want to pack too many in because the crystals themselves in the TLDs may perturb the beam, especially in the lung and soft tissue regions. So we'll need to do some optimization testing. And so when TLD spacing testing is done, we might do some design revisions to the MATLAB model and then print off some sections again. Then after the printing is completed, we'll move on to the cone beam CT measurements of the actual phantom itself, as well as the PCXMC simulations of the cone beam CT. And then if time permits, we'll do some revisions with film for skin dose measurements. And then we'll probably just add some film or maybe cut out some areas for film. And then once that's all done, we'll do an analysis and comparison of the dosimetry between the printed Christie phantom and the PCXMC simulations. So the 3 circles highlight the things that we've kind of already tested. So I did a feasibility report over around June, July, earlier this year. And we've done a bit of 3D filament testing, as well as some MATLAB designing, and as well as some basic prototype printing. So you can see here that I printed a attenuation tester for the different infill densities of PLA that we're going to use. So that printed and then we put it into a CT, and then we measure the HU values of all the different infill patterns and infill densities. And then we printed this with the Bamboo Lab Carbon with AMS, which is the printer that we have at the MedTech and Physics department. And then we also printed some small prototypes which test the ability of the AMS to print multiple filaments on the same level. And this is really beneficial for us because if we're going to print multiple filaments for the lung, the bone, and the soft tissue, it needs to be accurate in the printing process, and it proves so. And here's just my timeline of my study. So currently we've already completed some of the filament testing and some of the designing, but after that we'll need to do some actual measurements and then revisions and then proper analysis and finally my thesis writing. And here are my references. Thanks for listening.
That's great. Thanks, John. Again, another fantastic presentation. Does anyone have any questions for John?
Yeah, I have one.
Go for it.
Okay, John, so really interesting presentation. My question was, so regarding the simulation of bone in the Phantom while you're printing it simultaneously, can you give a bit of detail in what parameters and infills did you use for that?
Yeah, so we've selected stone fill PLA, which is PLA that's got 37% ground stone in it, which offers quite a higher density and quite a higher attenuation compared to normal PLA. We haven't actually done the test infill, like the HU testing for that yet, but we've printed off some prototype little cylinders like these ones. But yes, we've done some testing with the different filaments, and it's proven to actually print both filaments on the same level pretty well.
Okay, yep, great.
Siva, did you have a question?
Yes, thanks for the presentation. You indicated that TLD has its own uncertainty and all these things. Do you consider in your study or in your study in addition to the TLDs a GAF chromic film, or do you think because of the time limitations you don't want to cluster so many things?
Yeah, well, I mean, I've mentioned it here. Well, we might do some revisions with GAF chromic film. The only concern that I have is that GAF chromic film is, I was reading it earlier, it's accurate above 100 kV, and we want to test the Phantom from all the way from 40 kV all the way to 140 kV. So we might run into some uncertainty errors below the 100 as well. But also the main thing is that the price associated with GAF chromic film is quite a lot higher than TLDs, because we'll get TLDs supplied from Royal Perth Hospital.
Okay. Yeah. And clarify me that we use this Phantom once Rick run the software on one of the Phantoms. But this software doesn't account in our CBCT. We have a bow tie filter and all these things. I remember that it doesn't account. Is it correct?
Yeah, so I don't think the PCXMC software itself can account for it, but using AutoCalc scripting and a couple of other things, we can, because I read some studies where they actually did verification with bow tie filters using PCXMC.
Right. Good to know about it. Thank you.
Yeah, thanks.
Talat, do you want to go ahead?
Yes, thank you for this very nice presentations. And it's a unique way to do this thing. Just a quick question. When you're doing a PCXMC simulations, normally when you do these multicolor simulation, you normally give us the atomic composition of the material. So what you are actually what you are building up is not exactly the is not exactly the composition what the human body contains.
Yeah, so the filaments won't be directly, so for just for context, PCXMC offers data tables where they have different elemental compositions of the different tissues. So infant soft tissue, infant bone tissue, and lung tissue are the ones that we're interested in. And then the actual HU values or the X-ray attenuation capabilities of those tissues are calculated using the NIST database with the different KV values for each of those different elements. So we've analyzed those for a couple of, I think, from 90 to 120 kV. We need to analyze some more. But yeah, so we're going to base the X-ray attenuation properties on the filaments on those X-ray attenuation properties of the theoretical tissues within the phantom. Okay, so you're not doing the simulation on the actual phantom. You're doing the simulation on the basis of the human body anatomy materials itself. Are you doing a simulation on the phantom? No, it'll be based on the phantom composition. Oh, okay. Okay. That would be interesting. Yeah.
And one last question from Benjamin.
It's me. So just one point I wanted to mention, John, and your presentation was fantastic. About the films that you mentioned, GAF chromic has the limit. So there are some GAF chromic type films that are suitable for lower energies. We have some that have expired, but you can use the manufacturer to contact them, and if needed, you have that option.
Okay. Yeah. Awesome.
Great. Thanks, John. I think we'll leave it there. Again, thanks for the fantastic presentation. If you don't mind stopping your share, I'll stop the recording. Yeah.